Patient RL is a 74-year-old female admitted for diverticulitis. She has a nasogastric tube to low continuous wall suction. She is NPO for a potential exploratory laparotomy in the morning. Today she will be receiving D5 half normal saline with KCl. She has a dilated PCA. She will get Protonix, Zofran, Ansef, metronidazole, potassium, and magnesium oxide. D5 half normal saline with 20 milliequivalents KCl at 125 milliliters per hour. The pharm class is a hypotonic solution and an electrolyte cation. The mechanism of action is used to treat hypovolemia, maintenance IV fluid, and maintain K level due to the nasogastric tube to low continuous wall suction. The typical dosing is 20 milliequivalents per day at 125 milliliters an hour, and I'll be monitoring for fluid overload. I will educate the patient to use the ConVal for assistance when they need to use the bathroom and to report any pain at the IV site. The risks are fluid overload, and I will monitor for cardiac changes. The other monitoring that I will do are for signs of fluid volume deficit, such as confusion and dizziness. The dilated PCA is a 0.2 milligram per 4 minute, 4 milligram per 4 hour limit. The pharmacologic class is an opioid analgesic. The mechanism of action is that it binds to mu opioid receptors. The typical dosing is 8 micrograms per kilogram of IV bolus, or 2 micrograms per kilogram IV with a lockout time of 10 minutes. I will be monitoring the respiratory, cardiac, and neurologic status. I'm going to educate that they should be the only ones to press the green button. And the risks are dependency, addiction, abuse, coma, arrhythmias, abdominal distension. Protonix 40 milligrams IV push every day is a stress ulcer prophylaxis. The pharm class is a proton pump inhibitor. It binds to hydrogen and potassium exchanging ATPase, which prevents secretion of gastric acid. The typical dose is 40 milligrams per 10 milliliter every day, delivered over 2 minutes. I will be monitoring neurostatus, skin, airway and respiratory status, and IV filtration. For education, I will tell the patient to report any difficulty breathing, nausea, abdominal pain, and dizziness. The risks are anaphylaxis, headache, diarrhea, nausea, abdominal pain, vomiting, and dizziness. And the other pertinent information is that the 40 milligrams will be reconstituted in 10 milliliters of 0.9% normal saline. Zofran 4 to 8 milligrams IV push every 8 hours, or PRN, is for nausea and vomiting. The pharmacologic class is a serotonin 5-HT3 receptor antagonist. The mechanism of action is that it blocks action of serotonin, preventing nausea and vomiting. The typical dosing is 4 milligrams IV 1 hour pre-op, or 8 milligrams IV every 8 hours PRN. I will be monitoring cardiac status and electrolytes. For education, I will tell the patient to report any vision changes, headaches, loss of consciousness, and to avoid driving while taking this. And risks are seizures, chest pain, syncope, vision changes, skin irritation. And other pertinent information is that 4 to 8 milligrams should be reconstituted in 50 milliliters of 0.9 normal saline. Ansef 1 milligram IV every 8 hours. The pharmacologic class is cephalosporin. The mechanism of action is that it interferes with bacterial wall synthesis. The typical dosing for surgical prophylaxis is 1 milligram 36 minutes before, or 0.5 to 1 gram during surgery if it lasts 2 hours or longer. We will be monitoring her specifically because we need to monitor those who have a history of GI disease. For education, I'm going to tell the patient that we have to complete the entire course of therapy and have the patient report any watery, bloody stools immediately. And the risks are edema, hearing loss, dyspnea, bruising, and abdominal cramps. Metronidazole 500 milligrams IV every 8 hours is a nitronidazole derivative, which is an antibiotic. The mechanism of action is that it undergoes intracellular chemical reduction during anaerobic metabolism. The typical dosing to prevent preoperative bowel infection is 15 milligrams per kilogram infused 30 to 60 minutes before surgery. I'll be monitoring neurostatus specifically. For patient education, I will have a female patient, which I have, notify the provider if she's pregnant, and have patient avoid alcohol and have them report dry mouth. Risks are aseptic meningitis, abdominal cramps, leukopenia, back pain, and burning and stinging sensation. And this is contraindicated in breastfeeding, hypersensitivity to medication, and trichomoniasis during the first trimester of pregnancy. Potassium, 10 milliequivalents, and 100 cc of normal saline IV piggyback times 4. So first and foremost, I would just clarify with the provider the times 4. But the pharmacologic class is that it is an electrolyte cation. The mechanism of action is that it acts on the major cation in intracellular fluid. The typical dosing for maintenance and prophylaxis is 20 milliequivalents per day. So I would just double check with a provider because she would be getting more than that. I will be monitoring phlebitis and cardiac status. For patient education, I will tell them that potassium is part of a normal diet, and I will teach them how to take their radial pulse and tell us if there's any significant changes. The risks are confusion, paralysis, and arrhythmias and EKG changes, and it is contraindicated in dehydration and concurrent use of potassium-sparing diuretics. And like I said earlier, I would just double check with the provider about all the potassium she's getting. I know she is at risk for hypokalemia due to the low continuous wall suction nasogastric tube, but I would just double check to make sure that the amount of potassium she's getting is safe. Magnesium oxide, 400 milligrams by mouth every day. So since my patient is NPO, there are a few different ways I could go about this, but I would actually stop the suction on the nasogastric tube, and I would give this medication with a small sip of water and hold suction for about half an hour to let the medication do its job. The pharmacologic class is a cation electrolyte. The mechanism of action is that it assists in all enzymes involved in phosphate transfer that use ATP. The typical dosing is 1 to 2 tablets, so 400 to 800 milligrams a day. I will monitor electrolyte levels and evidence of hypermagnesia. The patient education is to avoid using magnesium-containing laxatives. The risks are confusion, syncope, arrhythmias, hypotension, and muscle cramps. And anything else pertinent is that it is contraindicated with hypersensitivity and heart disease. Thank you for listening to my TED Talk.